Welcome to the Pulmonary Embolism lecture. So hopefully this will help you get a better idea of what all is going on with a pulmonary embolism when you see it. One of the big things about pulmonary emboli, and it's just something to be aware of in the hospital as well, is it's a sudden acute change usually in the patient's condition. They'll be on 2 liters of oxygen and then they'll call rapid response. They went from being on 2 liters to being on 15 liters of oxygen, right? And so it's that sudden acute change that usually happens. This isn't usually a slow progressive process. Usually it's a sudden acute change where they had a blood clot that passed through the right side of the heart, through the pulmonary artery, hopefully through the pulmonary artery, and somewhere into their lungs. So this is usually a sudden acute change in their oxygenation. And then we'll get into some of the other things that you'll see, but that sudden acute change, especially for someone that has been unmobile for a while, like let's say a post-op hip or a knee replacement or something like that's going on, those all should raise flags to you if you're working in the hospital of, oh, could this be a pulmonary emboli, right? Could this be the reason why their oxygenation is so poor? And so we'll get into some of the things here, but I just wanted to stress the point where, hey, a sudden acute change in status could equal pulmonary emboli if some other things are present. So just be cognizant of that, just to sort of help you get the treatment a lot faster for these patients. All right, so this is where a blood clot has become dislodged and travels to another part of the body. It's called an embolism. Now understand, and I want to make this point, and it's something good to remember for a future assessment document, is that it is not only blood clots that could cause a pulmonary emboli, right? It could actually be a bone fragment, it could be air, it could be fat, it could be amniotic fluid, right? There's a bunch of things that can go and clog up perfusion in the lungs, right? And so that's one of the things just to be cognizant of. It's not only a blood clot, there are other things that can cause a pulmonary emboli besides a blood clot. I've experienced these in clinical practice, so I just want you to have that thought in the back of your head. Could this trauma where they have a broken tib fib, could that have a situation where they have a blood clot or a bone fragment that travels up and goes to the lungs and stops perfusion to a certain area? So that's something I just want you to be aware of. I want to stress that point. It's not just a blood clot. There could be other things as well. So that's what we're looking at here. We'll be primarily talking about blood clots because statistically that's probably what you're most likely going to see in most facilities out there, is that blood clot that travels. So pulmonary infarction may develop subsequently, right? So we have nice, good blood flow going through everything, and then we got this little clot that breaks off and travels to the lungs, and then once it travels to the lungs, remember our arteries go into arterioles and they get smaller and smaller. So once that clot travels, it blocks off blood flow to that area, right, as it gets smaller. So that's something that you just got to be aware of. As the arteries go smaller into arterioles, like the pulmonary artery, nice big round vessel, right? Used blood pulmonary artery, and then once it starts getting to the smaller vessels, as it traveling to the pulmonary capillaries, that's when those clots can get lodged. Now we can even have, and that's what it's talking about in bullet point down here, is we can have what's called a saddle embolus, where the pulmonary artery, right, here's your pulmonary artery, and it goes to the patient's left lung and the patient's right lung. So the pulmonary artery could have what's known as a saddle embolus. This is where we have a blood clot that forms right here. Oh, this should be purple actually, because it's venous blood. So we have a blood clot that actually forms here and blocks a lot of blood flow from going to the lungs. That's a very serious thing. The patient's whole top half from the collarbone up usually turns purple. Like it is a cyanosis that you will recognize. Like if you, I wish I could put a picture in there, but usually their whole top half will be purple with the saddle embolus. It's pretty severe overall. let's get into this. So if a blood clot is blocking blood flow, that means blood flow is infarcting, right? There's no blood going to that area of the lung tissue. So obviously if there's no blood going to that area of the lung tissue, right, we have no blood. Right, no blood that's flowing, right? We should have blood flowing there. And remember, the capillaries surround the alveoli, so then there's nothing really giving mass or weight to that alveoli. It's getting all its pressure from the inside, but it doesn't have any distensional pressure from the outside. So obviously with less blood flow, there's a higher chance of atelectasis for sure. Consolidation because of the atelectasis. Tissue necrosis. Now, keep in mind, remember the tracheobronchial tree has blood that goes to it that nourishes it separate from the blood flow going through the lungs. So it has its own blood flow, just like you have like your anterior interventricular artery of your heart, where it supplies the myocardium itself with blood. Same thing, your tracheobronchial tree has its own blood flow that go to it and nourishes it. However, your respiratory zone, blood flow for your respiratory zone, right? That is supplied, the blood flow that nourishes the wall of the alveoli. So the wall, or like the myocardium of your heart, that type 1 pneumocyte needs nourishment. It needs blood flow. It needs oxygen. It needs to remove its stuff, right? It needs all these nutrients, and the way it gets its nutrients is not through separate blood flow. It actually robs it from the blood flow through the pulmonary capillaries, right? It robs it. Now, it doesn't have a high metabolic rate by any means, but that's where it gets its nutrients. So if we block blood flow to the respiratory zone, we can cause necrosis of the respiratory zone, right? The respiratory zone, like I said, is where you get your nutrients for that type 1 pneumocyte. You get your nutrients for the respiratory zone with the capillary blood flow. Capillary blood flow shut off, so does your nutrient supply get shut off. And that's what can cause necrosis and breakdown of the respiratory zone. Occasionally, they can have bronchospasm with this, so that's why it's not a terrible idea for bronchodilators with a pulmonary emboli. Now, every once in a while, you'll see them wheezing with this. It's not the worst idea in the world. You just got to watch out for adverse reactions more than anything. But when we're looking at this, according to your book, according to the evidence out there, bronchospasm is a possible result from pulmonary emboli, right? And so when we're looking at this, you got to consider, could a bronchodilator therapy be indicated in this situation? Well, if the patient's having shortness of breath, difficulty breathing, coughing, so on and so forth, could that be something where a bronchospasm could be in effect? And if it could be there, should you treat it, right? Are they wheezing? Are they having difficulty breathing? Are they having that cough? Well, then, hey, this is where you discuss with the care team about considering a bronchodilator, because that is something that can happen with a pulmonary emboli. Big thing with pulmonary emboli when you're looking through this, it may originate from one big blood clot and break off and shower. And so you have a bunch of different areas in the lung tissue that are shut off to blood flow. Not good, right? This is pretty bad because this is going to interfere with the ability to perfuse the lungs overall. So that means not only the lungs, but we're not going to be able to exchange gas and actually get good arterial oxygenation as well. So this is one reason why you will see their saturations start to drop and their oxygen requirements increase, right? So you could have one large clot that just breaks off into a bunch of tiny ones and showers all over the place. That's not a good situation either. You don't want either. You don't want a large clot, and you don't want a showering of clots. Both of those will interfere with the ability to perfuse the lungs. Well, what do you think is going to happen to your pulmonary vascular resistance? I know I'm sort of jumping ahead here. Pulmonary vascular resistance is how much resistance the pulmonary vasculature is giving to the right side of the heart pumping, right? It's sort of, if I have a big vessel, so a giant open blood vessel, according to Posey's law, it's going to be very easy for gas to flow through there, or for anything to flow through there, because I have a big giant vessel, right? But if I make this vessel half the size, remember that's a 16-fold change in resistance, it's going to be a lot harder for blood to flow through there. It's going to take a lot more pressure for that flow to go through there. And so that means anything that's behind that area is going to have a back pressure that develops. That means there's stress on the right side of the heart, right? That's where your right-sided heart pressures can go up because your pulmonary vascular resistance increased. Hopefully you're starting to see this whole hemodynamics thing with PVR, SVR, all that good stuff. If not, we'll just keep going through it, right? Just keep on going. The more we do it, repetition's the key to learning. If someone has a saddle embolus, and we already talked about this one here, right, where it sort of sits at that pulmonary artery location, these are pretty quickly fatal and blocks a lot of pulmonary blood flow moving to the left ventricle, which means what would happen to their blood pressure? Right, they'd become hypotensive, right? And then that's very poor, because then we're not delivering blood to the brain, we're not delivering blood to the kidneys, we're not delivering blood to the heart muscle, right? So that's a very, very bad thing overall. And the blood that is getting there, is it very well oxygenated? Absolutely not, right? So there is a lot of issues going on with the pulmonary emboli. I know I drew all over the screen, but hopefully some of the stuff that I'm putting together here is helping you out a little bit. All right, so this is a picture from your book. Letter A, which is not pictured, is the pulmonary emboli that you're looking at here, that giant clot that's sort of sitting in that pulmonary artery. B is the bronchial smooth muscle constriction, right? That's that bronchospasm that can easily happen with this. So letter C over here is that atelectasis, right? And then letter D in the bottom right there is alveolar consolidation, and that's very common because of the anatomic alterations of the lungs. The lungs are going to be, hey, I'm getting necrotic, I'm in injury, I've been hurt because there's no blood flow flowing to me, so I'm going to release tissue response, I'm going to release cytokines, I'm going to release all these bad mediators of inflammation and swelling. So that's going to be one part that could easily happen with this, right? We're looking at consolidation, which what would happen to your shunt-like effect? What would happen to your ability to get oxygen into your bloodstream if you have consolidation, right? That's going to increase your shunt overall. All right, so lung alterations, right? This is that sort of that key thing. It's almost like there would be a summary slide that would ask you about this. The major structural changes associated with pulmonary emboli, and there are 4 of them. Infarction, when it's severe enough, right? We can have a couple little emboli there. You may have it for a couple days, minor chest pain, not know you have it, right? So pulmonary infarction, when it's severe enough, right? No blood flow, that's more common with your saddle emboli. Alveolar atelectasis, so you're looking at infarction, atelectasis, consolidation, so alveolar, so this is, remember, your respiratory zone consolidation. So airway clearance therapy, do you have a lot of cilia? Do you have a lot of those things in your respiratory zone, or is the respiratory zone mostly simple squamous? Right, simple squamous, doesn't have ciliated, columnar, so on and so forth. So airway clearance therapy, unless they have something going on, right, you be the judge. But alveolar consolidation is something that goes along here, that usually that dry cough, that J receptor cough, that dry non-productive cough can happen. Now sometimes hemoptysis can happen if there's a lot of necrosis going on, and alveolar consolidation, they can actually develop hemoptysis as well. So that's just something you might see out there. And then of course, bronchial smooth muscle constriction, also known as bronchospasm. Right, so these are the 4 things that can happen with a PE. All right, risk factors for pulmonary emboli. Pretty important. Number one here on the list is congestive heart failure. That's that left ventricular failure. And so when we're looking at CHF patients, they're not able to squeeze a lot of blood out of their left ventricle, right? The squeeze is sort of weak, right? So with congestive heart failure, that left ventricle is just sort of weak at the squeeze, which means, does it squeeze out a lot of the blood with each squeeze? Or is there a lot of blood that gets left over after the squeeze, right? So just like you know how when we talked about COPD and emphysema, how at the end of an exhale, if they have premature closure of their lungs, right? So here's your emphysematic. If there's premature closure of their airways, it's going to breath stack. It's going to back pressure. And that's going to cause alveolar hypertrophy, right? It's going to cause that distension. Their FRC will be increased because they're air trapping. Well, with left ventricular failure, remember that left ventricle is not squeezing very well. And so their end diastolic volume, how much is left over, very similar to FRC, right? They're cousins. One's of the lungs, one's of the heart. So their end diastolic volume here is going to be increased, or how much is left over. So now we have blood that's stagnant and left over. Well, if blood is stagnant, not moving, left over, it has an increased risk of developing into a clot, things like that. So that's something that we just gotta be cognizant of. Congestive heart failure. Why do I make a big thing about congestive heart failure for you? Remember, half of the patients that have COPD also have congestive heart failure, and half the people that have congestive heart failure also have COPD, right? And so there's a lot of comorbidities with this, and so you've got to be cognizant, what are my therapies doing to the heart? What are my therapies doing to the lungs? And is there something that's causing harm or something that would benefit both? Right, so just to be thinking about that. So congestive heart failure, inactivity, right? This is where we have people that are post-op hip, post-op knees, right? Post-op surgery type things. People that have gone on long international flights. Those are all things that can ultimately lead to developing this, because are you moving your feet and your toes and your calf muscles and your thigh muscles? Are you using those quite a lot, or are they sort of stagnant and still? Well, you need that muscle squeeze. You need that squeeze and movement to help maintain blood flow going back to your heart. You need that so blood doesn't stay stagnant. And when it does, it has a higher chance of forming a blood clot. So that's why post-surgery patients, they usually be on what's called DVT prophylaxis, right? They'll have these really tight white socks on called TED hose or compression socks, right? Or they'll have these things, the SEDs, that squeeze their lower legs, right? Things that will help blood flow and help avoid a clot from forming, so therefore we avoid a DVT. Remember, a DVT is a deep vein thrombosis. Well, the thing about a DVT, if we can stop them from developing a DVT in this situation, if we stop the DVT, there's no blood clot that can then travel to the lungs. Right? We stop that natural progression there. So if we're able to avoid DVTs altogether, if we give them a low-dose heparin, to help avoid blood from clotting, if we give them these compression stockings, if we have them be active, things like that will help avoid that clot from forming in the first place. And if we stop that, then we'll stop it from ever going to the lung and causing a PE. Where we're worried is if someone is not under DVT prophylaxis and they have a sudden acute change in their saturation or oxygen requirements, then that tells us that they could have had a DVT that traveled and now they might have a pulmonary emboli, right? We'd have to confirm it, but that's just something that we'd be thinking of. So DVT prophylaxis to a respiratory therapist is a very important thing to understand, especially if you show up to a room where someone has a sudden acute change in their oxygen status. What were they on for DVT prophylaxis? Were they on low-dose heparin? Did they have compression stocks? Were they active? Were they inactive? Right? Those are all things that could be useful and sort of indicating, could this person have a big risk factor for having a pulmonary emboli? As far as post-trauma goes on here, especially with injury and contusions and blood and bruising and all that bad stuff, of course, there's a big issue there. Not only that, but with pain and mobilizing, walking around and all that stuff, may not be something that is suitable for them in their current state. So that obviously can put them at a higher risk for blood staying stagnant, hypercoagulation disorders, DIC, disseminated intravascular coagulopathy. So when we're looking at DIC, that's something where your body both clots and bleeds at the same time. Now, some people will clot more severely than they bleed, and so they'll develop clots that go to their lungs, or some people will have more of the bleeding issue and they'll form bruises, and then you'd have to give them platelets, right, to help them clot better. So things to look at there hematology-wise. They could be at more risk with hypercoagulation disorders. Hey, what's this one? Oh, people that smoke are more at risk for pulmonary emboli. Yet another strike against smoking. Go figure. So that's just something obviously that's well known and well documented out there by multiple sources and multiple studies. Definitely a higher risk for this. And now you add smoking on top of having congestive heart failure, on top of having post-surgery, right? You're looking at a brewing or a cocktail that will lead to a high probability of a pulmonary emboli, right? Burns, of course, burn victims, people that have different types of catheters, like in arterial line. Arterial lines, especially in central venous lines, you're looking at those lines, and usually we won't leave them in for too long because they can cause necrosis and breakdown, but also blood can clot and attack the actual indwelling catheter, and therefore cause a blood clot that can travel to the lungs or the brain or the heart, right? MI, PE, CVA. So things like that we have to be very cognizant of as well, besides infection. And we'll get into more of these catheters, especially when we go into critical care techniques as well. Pregnancy and childbirth. So pregnancy, especially when we're looking at third trimester, there's a lot of compression on the inferior vena cava by the baby inside, and so when there's a lot of compression on the inferior vena cava, blood flow going from like the legs and the feet and the toes and all that stuff is impeded, and therefore more likely to stay in their feet, ankles, toes, and all that stuff. So that's one reason why in third trimester there's more swelling of the feet, ankles, right, all that stuff going on. Well, that also means there's stagnant blood, there's a higher chance at blood clotting as well. Also, all the hormones that go on with pregnancy and childbirth can easily lead to more of a chance of clotting, and it can mess with your clotting ability as well. So it just sort of depends. Some people, I've had cases where someone has gone into DIC as part of the pregnancy thing and childbirth thing. So just be aware there's a lot of hormonal changes that could easily play a factor into the clotting and to playing into a PE. And I told you guys about that young woman, that like 14-year-old that had just started taking, 13 or 14-year-old that just started taking oral birth control, and so she came in, her oxygen, she felt chest pain, her saturation was low, and I did an Untitled CO2 nasal cannula on her, so I measured how much CO2 she was exhaling and then how much CO2 was in her bloodstream, and there was a big discrepancy between the two, right? That's not normal. Normally they should be within like 5 millimeters of mercury of each other, and she was much farther than that, and so I was able to see, okay, so there's not a lot of blood going to her lungs, right? Going to the point where she's exhaling a lot of CO2. And so that tells me that compared to her, how much CO2 she's exhaling, compared to how much is in her artery, there was a big discrepancy. So that told me that there was something like a PE going on. So things like that, just be aware, little things like that. And that's not the only case out there. It's more common than you might think of that supplemental hormonal birth control that can easily make someone more prone to clotting. All right, bedside evaluation. What does this patient look like at the bedside? What would you see? So put your imaginary Pima scrubs on, your Pima stethoscope. You're working in an ER at NBRC hospital, right? Wherever you want to work at. So imagine you're there. This person shows up to the ER. What would they look like? Well, one of the big things, or you get called to a room, what would this patient look like that had a PE? Well, one of the biggest things, and that's why I put it in bold here, is that sudden onset is usually a key tipping point. This disease or disorder hasn't been going on for too long, and this is usually a very quick, sudden change of status for these patients. So that's something to know. Hey, has this been going on for a couple of days, or is this something that just happened a couple of minutes or hours ago, right? Some of these patients will notice pain that is worse when they breathe in, so under inhalation, right? Anxiety, of course, can be a part of this. Anxiety should be one of the ones just on the list. But pain that's worse when they breathe in is very much a symptom that could go along with this. Of course, cyanosis, we're blocking blood flow, right? We're blocking a lot of blood flow from going to the lung tissue and getting oxygenated, right? And so obviously, if we can't pick up oxygen, right, the blood flow is not getting there, not getting to the lungs. It's being stopped before it ever gets to the lungs, right? Before it ever gets to the capillaries, I should say, right? It's being stopped before it gets to the AC membrane, right? It's getting to the lungs, but maybe not to the respiratory zone. So if it's stopped before getting there, we're not picking up oxygen, right? We're not picking up oxygen. We're not getting rid of CO2, right? We're not. None of that is happening. We're not having functional gas exchange at this point. So obviously cyanosis can happen. Of course, we talked about the cough, how alveoli will infiltrate. They might also have bronchospasm. Both alveolar infiltration and bronchospasm can cause a cough as well. Wheezing, fine crackles, especially these can easily go with atelectasis and alveolar infiltration and bronchospasm, hence bronchodilator. Maybe not the worst idea in this situation. Leg swelling and edema, that's where you'll see the doc pull back the covers on their legs or feet, and then look at their feet and sort of see, if I just touch their ankle, will my fingerprints stay there after I release it, right? So I'm looking for edema and swelling, something like that. Obviously with cyanosis, tachycardia goes along with that. Arrhythmias can easily be a sign of cyanosis too. Right bundle branch block, RBBB. Just keep saying B's. Right bundle branch block, right ventricular strain patterns can easily be seen on their EKG. So if someone comes in with chest pain, are you going to do an EKG? Well, most likely, as of the recording of this, most likely you will be doing an EKG on this patient, or they will get an EKG. And so arrhythmias can also be secondary to, remember, hypoxemia, as well as strain on the right side of the heart. Is there right ventricular strain on the heart? Absolutely, right? Remember, our pulmonary vascular resistance increased, and that back pressure and put strain on that right ventricle, which means could there be a sign that shows up on my EKG, my electrical activity? Absolutely, right? So right bundle branch block, right ventricular strain, a right axis deviation can also be seen there. Blood streaked sputum, we talked about this with a little bit of blood streaked sputum. We talked about this a little bit of hemoptysis is what I was saying, but that blood streaked sputum is more with that necrosis that can happen, or a severe injury, and edema, of course, can easily happen. Hypotension, of course. Are we sending a lot of blood through that area of the lung that can then be dumped into the left side of the heart? No, right? We're not sending a lot of blood to the left side of the heart, and therefore hypotension could result. Jugular venous distension, remember this is because our pulmonary vascular resistance is increased, and therefore back pressuring our central venous pressure, right, which would cause a JVD. So remember, a JVD is a bedside way of seeing what's going on with the right-sided heart pressures, right? So obviously if JVD is present, that could be indicating their right-sided heart pressures are elevated. Do I need a flow to Swan-Ganz catheter to determine that? Absolutely not. So that's one of the things you might see at the bedside, JVD. So they might raise the patient's head a little bit to look for JVD. And if it is there, that's a sign that there's strain on the right side of the heart and there's a lot of back pressure. Of course, these patients might have an altered mental status from syncope. So obviously syncope, low blood pressure, can cause confusion. Yeah, they could be in an altered state of mind altogether. So be aware of that. They might not be completely there as far as being able to answer a lot of questions, and that's why getting a good history or getting a good story from the family is going to be very helpful. All right, x-rays. Here is what's in bold, and be understanding of this. Usually there's no radiographic signs. In other words, we get an x-ray, no cardiac or pulmonary disease noted, right? It's a normal chest x-ray. They don't see anything abnormal. This is in bold, right? Circle this, put a star next to this, put this in your study guides, right? Patients with a pulmonary emboli often demonstrate no radiographic signs. In other words, you don't see it. So why do we still get an x-ray? Well, especially when there's chest pain, we're trying to look at what it could be as well as rule out things as well. So not only is it for looking for something, but we're also going to rule out other things it could be, right? Could it be a pulmonary disease, right? Could it be something else going on? So we're still going to get the x-ray. Just like the EKG, we're still going to get the EKG to rule out a MI or acute, anything that could be going on there. But a lot of times what we do x-rays is more to rule out and to verify type thing, and that's a whole separate lecture. But still going to get it, but most of the time you won't see anything on the chest x-ray. If you do see it on x-ray, so this is in the case of you do see something on their x-ray, so pretty significant PE, you would see a lot more density, so it'd be radio opaque in the areas where there is low blood flow, right? Because that area is going to be collapsed, consolidated, and there's no blood flow there. So you're going to see a lot more radio opacity in that area. You might see radiolucency behind the emboli, right, in the area that doesn't have the issue going on. So that's going to be a sign. You're going to see contrast, right? You might see decreased vascularity. This is known as a Westermarck sign. Do I need you to remember that term? No. But it's good to know. Dilation of the pulmonary arteries, especially because, why would there be dilation of the pulmonary arteries? What did I tell you about? Pulmonary vascular resistance, not SVR. Pulmonary vascular resistance is increased. So that means that we're back pressuring the pulmonary artery, which means that pulmonary artery diameter or size can appear larger if PVR is increased. I hope that makes sense. Pulmonary edema, of course, all the area behind the infarction. So we got this area of infarction right here, but let's say we have this alveoli that's behind that area. Well, now we have a backup of blood flow. What's going to happen with the osmotic pressure? Remember, our PVR is increased, so we're going to have a lot of pressure backing up, right? Congestion, just like a traffic jam behind a car accident. A lot of congestion, right? A lot of pressure here. And so the pressure is going to exceed the vessel pressure, and it's going to leak into the alveoli, causing pulmonary edema, right? Pulmonary edema decreases or dilutes surfactant as well and causes atelectasis, and we'll talk about that. So that's going to be one thing that you'll see here. So yes, pulmonary edema is a part of this because especially for those areas previous to that clot, they're going to have that back pressure, and all that alveoli is going to fill with that excess pressure, right? Goes high concentration to a low concentration, and that's where we'll see pulmonary edema come into play. And then this one becomes atelectatic. So when we're looking at right ventricular cardiomegaly or cor pulmonale on the x-ray, that's a lot of that back pressure pushing against that right ventricle, so the right ventricle is going to get bigger. Pleural effusions can happen with this. Usually they're pretty small. This is because, remember, we have an increase of the right-sided heart pressure, so that's going to put a lot of pressure on the lymphatic tissue and everything, and they could get a small pleural effusion with it. All right, here is a chest x-ray. So this one is not normal. Obviously, there's something being pointed to. This is the arrow that you see being pointed to here. Is a backup of blood on the right, which means decreased blood flow to the left. So that means the left lung has the infarct here, and the right lung is seeing all that back pressure, right? And that's why you see that giant, dense, radio-opaque tissue that the arrow is pointing towards. This is what's known as a Westermarck sign, right? I want you to be like, hey, this side is a lot of radio opacity. And it's very dense, not like allostatic dense, but very dense. And then you see this is all pulmonary edema. These are curly B lines and then curly A lines. We'll talk about those when we get to pulmonary edema. So we have an infarct that's blocking the left lung from getting blood flow. So the pulmonary artery pressure is increased. And so that right lung is being back pressured, and that's where you're seeing all that extra perfusion there. You're seeing density or vascular density on this x-ray. Isn't that crazy? Okay, so what can be a little bit more detailed when we're looking at a pulmonary emboli? And on your picture to the right here, these are all emboli that have been extracted from saddle emboli, right, where it sits right on that pulmonary artery, where it doesn't travel all the way to the AC membrane. Blocks off way more lung tissue when it's a saddle emboli, right? It blocks off way more lung tissue. And then these are either autopsy or extracted emboli. So it's a pretty severe, significant thing with the saddle emboli. So I thought you should see some gross pictures because, you know, makes the lecture more interesting. So when we're coming to the CT with the contrast highlights blood vessels. So whenever we give a patient IV contrast, that sort of helps us see what's going on with the vascularity. Is there a lot? Are there a little? Is there no vascular? What's going on? So this is the first line. It's becoming the first line diagnostic tool to confirm a pulmonary emboli. So in other words, someone comes in, they're short of breath, they have all these things, a sudden acute onset, they were just started taking estrogens, supplementation, right, so on and so forth. And we're starting to go into all these things that would lead to a possibility of a PE. They might go ahead and just do a CT with contrast versus a chest x-ray. Now, I'm not saying they wouldn't do the chest x-ray as well, they might, but a CT with contrast is becoming a very quick, good diagnostic tool to confirm if they have it. So with this one, we're going to see a dark area where the thrombus is, and it's going to be outlined by the brighter contrast of the blood flow. So let's look at some of these. All right, I love this. This is a anterior picture, so obviously you can see the heart and the ribs and the right atrium, and you see how radio opaque this area where the dense clot is, right? Remember, it's dense and it's radio opaque, and so it's very thick and dense, right? And so you see the normal pulmonary artery, and then you see that thrombus where you just have it sort of stuck. So here is, let's switch to yellow. Here is that very dense thrombus, right? Very, very dark, very dense thrombus that's blocking blood flow altogether. So on the patient on the left, right, this is showing a normal pulmonary artery blood flow. And then on the patient on the right, this is showing blood flow from the right atrium to the right ventricle, and then it just stops, right? There's a little bit that squeaks past it, not much, right? Not much. So it's going to be very hard to perfuse the lungs and ultimately send blood to that side. So in this person here, obviously that's a big block, right? So that's a major block when we're looking at this. What they highlighted here was the superior vena cava, and you see how much back pressure there is on the right atrium and on the superior vena cava, right? That's that where you would see JVD, right? You'd see jugular venous distension up here next to their neck and all that stuff. So they're just trying to show what you would see as far as back pressuring. This is another great picture. I love CT scans. This is also a saddle embolism CT scan. So here you have the spine, and up here you have the sternum. All right, and then obviously remember these are mirrored images. So this would actually be the patient's left lung, and this would actually be the patient's right lung when we're looking at this. So when we're looking at this, here is the aorta, the ascending aorta, and then the descending aorta. So the aortic arch, we're just under the aortic arch, right? Normally the aortic arch comes over, right? We're right below the aortic arch, right? So we see the ascending aorta and we see the descending aorta. I'll highlight those for you real quick. All right, and so what you see here, let's go to purple. What you see here is the pulmonary artery. Now, I can highlight the respiratory stuff, but let's look at the blood stuff first. So here's the pulmonary artery. So you see blood flow, you see the contrast is bradyo-opaque, this bright white stuff, but now you see this area here and this area here that's radiolucent. Well, that is the clot. That is the thick, dense clot that's not showing up, because remember, we put dye in there to turn anything that's blood flow white. Well, obviously that's not blood flow if that's a clot and just stuck there. So this is a saddle embolus sticking right there at that bifurcation of the pulmonary artery for the right lung and the left lung. Isn't that crazy? Now on this as well, we're just below the carina, so you see the right main stem and the left main stem bronchus as well. So just to point out some respiratory stuff for you when you're looking at this. But yeah, absolutely. That's a saddle embolus right there. You don't need to memorize this. This is an extra slide, not in your book or anything. This is called the Hampton's hump sign, and I put that in there. I had a doc that was very strenuous about the Hampton hump sign, so just more FYI than something I would stress to you right now. When we're looking at this, you see that there's a filling defect, which is a fancy word for there's no blood flow in the left pulmonary artery. So once again, in CT scan, down here's the spine, up here's the sternum, and this would be the patient's left lung. So you can see how this dense, dark area, this radiolucent area, that's that clot. That's the embolism itself, right? So we have that pulmonary infarction secondary to pulmonary embolism. There's no blood flow because there's a giant clot there. And so this one also shows some bilateral pleural effusion. I'll try to highlight that down here. You see this extra fluid that's hanging on down here. Here's the ascending aorta. Here's the descending aorta. And then this is the pulmonary artery that we're looking at here. So the Hampton hump sign is right there, and you see on the left part of it, you see all that subsequent atelectasis and collapse of tissue, all that bad edema, consolidation, all that bad stuff, because that area just has no blood flow anymore and it's dying. All right, so we went over X-ray signs, we went over CT signs. Now let's talk about something called a VQ scan. Remember, Q is a way of looking at perfusion. Remember the shunt equation, QSQT. Q is the QRS complex and the EKG representing ventricular contraction, hopefully. So when we're looking at a VQ scan, this is something that was covered for a long time, and they still do these. It's sort of being replaced with CT scans, where they do a CT with contrast ultimately. But in this, you'll see areas that have ventilation as dark areas, and areas that do not have blood flow will show up white. So we're just comparing these areas. So I know that sounds like a foreign language, and you're like, Derek, what are you talking about? Well, let's practice. Okay, so I believe I took this one directly from your book. This one is a fat embolism. Like I said, remember, it could be more than blood clot. It could also be fat, bone, amniotic fluid, air bubble, right? There's a bunch of things that can cause it. So this is a fat embolism in a patient that presented with dyspnea. They felt short of breath. They were hypoxic, and then they just had recently had an orthopedic procedure. So they were post-op, whatever, hip knee, whatever it is, some sort of orthopedic procedure. The perfusion is the one marked P. This is the upper one. And then when we're looking at the ventilation, that's the bottom one with the V on it, right? Ventilation. And so we're seeing issues here because when we're looking at perfusion and ventilation, when we're looking at ventilation, what we'll do is we'll nebulize, or you will anyway, a radioactive material to the lungs. Right? What happens there is they'll be breathing it in, and then that should be spread. So we see the alveoli and the respiratory zone all receive that radioactive material, and then it shows up as radiolucent, right? When we're looking at perfusion, we should see it equal. We should see the same areas. We should see the same radiolucency. They should be identical. If there is no filling defect, if there is no perfusion issue, these should look identical. If they do not look identical, especially if the perfusion does not look identical, that means all these areas of opacities, hopefully you can see this, I should have used yellow. All those areas of opacities are equal to low perfusion. In other words, we have a pulmonary emboli. We have area of blood flow that's not getting blood flow, right? We have an area of lung that's not getting blood flow. So this is a VQ scan. So the big thing to remember with a VQ scan is we're going to nebulize something, we're going to look at the ventilation, and we're going to compare it to the perfusion. If they're not identical, then that means there's a perfusion defect, right? And that indicates an embolism. Hopefully that makes a little bit more sense. Like I said, you're just comparing and seeing, hey, do we have an equal symmetry here? If we don't, then we have a perfusion defect, and we can actually sort of see how different or how severe it is from this. All right, pulmonary angiography can be done. It's very rarely done, and it's just more in here for completion's sake. This is where they take a catheter, and this is usually done in the cath lab, and they go through the right side of the heart into the pulmonary artery. Then they put a dye in there, right? And then that dark area where they see it on the angiogram, right? They can sort of see how much blood is flowing past there. But the big thing here is it wasn't any considered superior to high resolution CT scans. So that's why this is something that can be done, but is sort of being replaced. So angiography is a way of looking for the clot, not a therapy. It's a diagnostic tool. So your book does talk a little bit about it. It's just not done too frequently out there. Okay, so this is the picture of a pulmonary emboli on an angiogram. So this is what they would see if they did pulmonary angiography. And you're going to see a lot of filling defects. And these are these little black dots that these arrows are pointing to. Do you see all the radiolucent areas that these arrows are pointing to? Yeah, that's what it's looking at. So this is showing that there's a lot of occluding emboli that are being seen on this lung overall. So that could indicate why this patient has such severe issues. And as you can see too, right, everything downstream of these clots are also radio-opaque. It's pretty crazy. So that's showing that blood flow is just decreasing everything downstream. All right, so you have your PEMA scrubs on, your PEMA stethoscope, you're working in the emergency room or whatever, and a patient comes in with a pulmonary emboli. You see all the classic bedside signs and symptoms. You're giving them oxygen. What would their ABG look like? So we do the ABG to sort of see how severe they are, right? If it's a mild to moderate, it'll be alkalosis. But why is it alkalosis? Remember, it's causing Cyanosis. I know my drawing's not too great here. Cyanosis, which then means your brain stem sees you don't have oxygen, so it's gonna tell your body to breathe faster, breathe deeper, and get rid of CO2 so you have more parking spaces for oxygen. So they'll be in that respiratory alkalosis state. When it gets severe, in other words, their whole body becomes hypoxic or hypoxemic, that's when it'll get into that respiratory acidosis, especially if they've been working hard to compensate for their low oxygenation. So just understand this is not a hypercarbic condition by any means until it gets into the severe stages where their work of breathing has caused respiratory fatigue. They can't keep up with their low oxygen levels anymore. But overall, it's an oxygen issue, not a hypercarbia issue when we're looking at this. All right, oxygenation. Uh-oh. This is a shunt-like process. Oh, heaven. So we have a shunt-like process going down. That means oxygen therapy is on the board. We're going to use oxygen therapy, especially high FiO2 oxygen therapy, enough to get them to a good saturation level that's adequate for their condition. DO2 is going to be decreased because our CCO2, remember, CCO2 is capillary content of oxygen. Our CCO2 is going to be decreased because we have something blocking blood flow from getting it, right? If our CCO2 is low, that means our CaO2 will also be low, which means our DO2 will also be low, right? So this should sound like a broken record, me going through this whole thing. Repetition's the key to learning. Their oxygen consumption, their metabolic rates, should be normal unless they go into some sort of severe metabolic acidosis from hypoxemia, right? That's a whole separate thing, but just with a regular PE, their metabolic rate should be normal. O2-ER is increased because the DO2 is low. Venous saturation is decreased because O2-ER is increased because DO2 is low. Broken record. All right, hemodynamics. Okay, so let's look at the right-sided heart pressures. Our CVP, right atrial pressure, pulmonary artery pressure, pulmonary vascular resistance, right ventricular stroke work index. So CVP is high, right atrial pressure is high, pulmonary artery pressure is high, right ventricular stroke work index, or how hard the right ventricle is working, is high, and pulmonary vascular resistance, which is where our car accident is, where our issue is extremely high. So right-sided heart pressures with pulmonary emboli are increased. So JVD, jugular venous distension, right? So these are all things that you might see. That's why you might see on an X-ray that if they comment that the the pulmonary artery is bigger than normal, that's all a sign of that right-sided heart pressure is being elevated. You might see edema in their feet and their ankles, things like that. Okay, so let's look at their left-sided heart pressures. Look at the right side. What about their left side? So pulmonary capillary wedge pressure, cardiac output, stroke volume, systemic vascular resistance, left ventricular stroke work index, or how hard the left ventricle is working, cardiac index, stroke volume index, all those are normal or decreased. So the left side is either decreased or normal. This is usually because the decrease is usually because we're not sending a lot of blood to the left side, so therefore we don't have a good cardiac output. We don't have a good stroke volume. We don't have, the left ventricle is not working near as hard because there's not as much blood dumping into the left ventricle. Right? So if you take a load off, right? If you're walking with a weighted vest on and you take the weighted vest off, you're not working as hard, right? So that left ventricular stroke work index is going to go down, right? So you have that lack of blood flow that causes that sort of low blood pressure, that low level there. Systemic vascular resistance, this doesn't change the dilation or the constituency of your arteries, right? Your arteries won't constrict or dilate unless you're in like a fight or flight situation, right? But usually your systemic vascular resistance isn't going to change at all. So right side of heart pressure is increased, left side is either decreased or normal. All right, how do you diagnose a PE? Well, usually this is more based on the clinical manifestations. That's right. What does it look like? What does it appear like, right? So pulmonary embolism, they might do what's called a Wells scoring system, and you can look that up. I'm not going to test you on scoring a Wells scoring system, but you should know about it and be familiar with it, especially if you're going to work in emergency medicine for sure. This is where they're looking at the probability. This is most likely a pulmonary embolism, right? So that modified Wells scoring system is something they use. They could also use radiographic, CT, X-ray, even ultrasound. I won't do an ultrasound with this one for you guys, but those are radiographic ways they can look at it too. But they can also just look at clinical manifestations and go from there as well. Clinical manifestations, you can sort of see how severe it is depending on their level of oxygen requirements, shortness of breath, so on and so forth. There is no single EKG pattern that will diagnose someone with a pulmonary embolism. Remember, the EKG would usually be signs of right-sided heart strain, so the heart's working hard. Which, is there any other pulmonary cardiac issues that could cause the right side of the heart to work hard? Absolutely. Any of them that can cause right bundle blanches? Absolutely, right? So it's not specific. You can't just get an EKG and diagnose someone with a pulmonary emboli. It's only going to be part of what's going on with the patient or how severe the condition is. All right, someone has a pulmonary emboli. What do we do? What are your interventions? What do we do with this patient? Of course, this one's going to be the big one immediately. Start them on oxygen therapy. This is a shunt-like condition. We're going to have issues where we just need to optimize what blood flow they do have going through their lungs, especially to avoid heart strain, especially the right side of the heart strain, right? Heparin, of course, especially if it's a blood clot, something that reduces the ability for the something that reduces that ability, or something that can help break down that clot. Embolectomy is a last resort. That's where they go in and remove it, like a surgical removal. Bronchodilators, if they're having bronchospasm issues, cough, wheezing, so on and so forth, not the worst thing in the world. No is nitric oxide. I like this, especially if their whole top half is purple and they're having a saddle emboli, right? Something huge like that. That's something where it's like, hey, what if we put them on nitric oxide? Well, nitric oxide is an endothelium-derived relaxer, which is fancy words for saying it's a pulmonary vasodilator, which means if I have a blood clot, and it's clotting up all that tissue, right? It's clotting off blood from going past here. If I dilate, if I now vasodilate that area, and the clot's sort of the same size, let's say it's just stuck to the wall of the vessel there. So if I vasodilate, what should I have drawn here? Now I'm able to get some blood to flow past it, so I can help relieve the VQ mismatch that is going on, right? So there's still blood clot, there's still turbulent blood flow in there, but now I got some that's moving past there. So nitric oxide could be an option for this patient as well, or any type of pulmonary vasodilator like iloprost, Flolan, like there's other drugs besides nitric that can be used. So that's just something, if it's severe enough, that could be used. And obviously the best thing, and this is sort of preventing it in the future, right? Smoking cessation, not sensation, cessation. Stop it. Stopping smoking, staying active, drinking plenty of fluids, wearing compression socks. They used to wear IVC filters. I think that's sort of a controversial thing nowadays, but I still have that in there just for completeness sake. But preventing it from happening again is a big issue or big thing to look at. Okay, review questions. What are the 4 common lung alterations that occur with PE? All right, this patient's coming into the emergency room. You're at the bedside and they have a PE. What signs and symptoms would they show? Would they have abnormal breath sounds? Would they have normal breath sounds? Would they have JVD, no JVD? Would they have shortness of breath? Would they have tachypnea? Would they have chest pain? What would they have? Right? What would you see? X-ray. Anything abnormal about most of their x-rays? If there is something abnormal, what signs could appear on their x-ray? What would you see if it did show up? ABG, what would the initial ABG look like in mild cases? What about severe cases? Oxygenation, what happens with their DO2? What happens with their metabolic rate? What happens with their shunting? What happens? If you did a PFT after their initial insult with pulmonary emboli, in other words, they're not in their acute phase, right? They're in the recovery phase of things. What would it show? Ooh, we didn't do a PFT slide. We talked about this restricting expansion of the lung tissue. So with restrictive disorders, what happens to your volumes? Your volumes will be, and your flow rates will be. Okay. Anything abnormal about their sputum? Ooh, that's a good one. Could there be something abnormal in their sputum? Could you see anything odd about their sputum color? What about their hemodynamics? What happens with their right-sided heart pressures? What happens with their left-sided heart pressures? Why does that happen? Explain the pathology of why those pressures are increased or decreased. All right, your patient has a pulmonary emboli. What are some suggestions? What are some therapeutic interventions that you can use to help this patient?